You did a great job presenting the data about the OS with the maintenance study. I think what is important in the forest plot you showed, the curve, the study that's pulling it to the right is actually the IFM study, which is kind of what we saw, the CALGB versus IFM. Why is it on this side of the Atlantic we see an OS benefit and the other side you don't? And I think we have to remember when studies are designed, and if the primary endpoint is PFS, OS is an exploratory endpoint, and it's going to be confounded by salvage therapy. And so what's interesting, in 2005, when the IFM study was done, if you got len maintenance and you progressed, 50% of patients in that study who progressed went on to get more IMiD therapy, which doesn't make sense because if you're refractory to len maintenance and you get more IMiD, possibly thalidomide, which is an inferior IMiD, is it surprising that you may lose the OS benefit that you gained from the maintenance? Whereas in the US, there was more appropriate salvage with PI. So I think it's, again, a bit of a stats nerd. I guess I find these interesting, but I think it's really important when we look at OS, which is, if that was not a predefined endpoint and you're not controlling for salvage lines of therapy, you really cannot speak definitively about the impact of your intervention for long-term sequelae.
And I think those are very valid comments, and it kind of speaks to the fact that we always have to go into the details of the data and not overinterpret. When we pool data, there will be a lot of those nuances. So if you go and look to the duration of the therapy, that was also a big difference.
Yep,
so the
absolutely.
Yes,
IFM
that's a
study,
huge difference.
they presented at ASH in 2009 that they had found 7 cases of secondary malignancy, and that triggered a alarm throughout the French group. So they stopped the lenalidomide maintenance after a median duration of about 2 years, while the American study kept on going. And when the investigation was completed, the conclusion was that it was more benefit than risk. So the American study kept on going.
As confirmed by an OS benefit.
Right.
So that's where you have the difference in overall survival. So maybe it's also the duration of the maintenance.
Yes.
There is also a dosing difference. The CALGB study allowed up to 15 milligrams, while the French study was 10 milligrams. We don't know if that is contributing or not, but that's also another nuanced difference between the two studies there.
Right. There was this presentation at ASCO this past year suggesting that higher len maintenance was better, although it was a smaller study, and so maybe even the 5 milligrams difference made a difference.
And I think it's also worth mentioning, again, it's great to have options for patients. Len maintenance has the most robust data, as you've shown beautifully. But I think we heard recently from Takeda, the top-line release, that ixazomib maintenance showed superior PFS benefit. And for patients with those who have 414 in particular, might a PI oral drug be a better choice? Emory has also presented a combination of PI and IMiD. And
Actually,
there's also a DARA maintenance study.
Yeah, now that there will be with the Griffin, and I just want to bring this point up because now you have big data, right? You have this, meta-analysis. It doesn't get better than randomized controlled trials and all of that, but we have smaller studies. And so if this person was with you, should the patient receive maintenance therapy? I mean, I think that for a lot of us, we say, okay, but then what would you do? Would you just say, I have the most data with len and you're going to get len, or do you take these smaller studies into consideration? What would you do?
I might actually offer this patient ixazomib because of the 414 translocation. I think historically len has improved but not overcome high-risk features, and I think the inconvenience of giving other parenteral proteasome inhibitors makes ixazomib another choice. But again, I think we have to also think about the patient tolerability and issues like neuropathy versus thrombotic events, myelosuppression, diarrhea. So each drug has its own unique profile. And the other point I would say is I always tell patients, maintenance should be mindless. If you're miserable on maintenance, I think we're defeating the purpose. I want my patients to live longer and better, not just longer with misery.
Yeah, actually, I'm so glad you brought that up because now we have more of our studies incorporating the PROs and quality of life analyses, and that is so critical, especially in this age group where people have long-term treatment and they need to know, are they going to be able to make it to family events? Can they work? As I always say, 70 is the new 60, so you want people to be very functional. What about you, Ola? Would you give this patient maintenance, and if so, what, given the details of the case?
I would have a conversation with the patient and say that the standard of care in the United States would be to consider maintenance, and I would say that there is this meta-analysis showing there is an overall survival benefit, but say also that it's 1 out of 3 large studies that really showed overall survival, the other didn't, so that's kind of what the data is. I say for sure there is a progression-free survival benefit, so in that light I think if the patient is interested in taking a pill 3 out of 4 weeks and with the main target to prolong progression, I think that would be justifiable to do that. Most of my patients would do that. I would offer them lenalidomide. I think ixazomib is a valid option. If you look at the NCCN guideline, they would suggest that you can use Velcade every other week, and also you can do ixazomib as single drug. Lenalidomide for sure has the longest track record. There are more studies, more patients, and that's why we have the PFS and overall survival data. I think just for the discussion here, it's important to emphasize that there is no randomized study at this point that has compared lenalidomide to ixazomib or lenalidomide to Velcade, proving superiority or inferiority. So that information we don't have. So it's a judgment call.